Good morning, everyone. So we have quorum, and I will call this first meeting of the Board of Health for 2020 to order. So welcome to members of the board, to the other members of council in attendance today, and to members of the public. You can follow the agenda and debate on your computer, tablet, or smartphone at www.toronto.ca/council. The Board of Health acknowledges the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Are there any declarations of interest under the Municipal Conflict of Interest Act? Being none, the first item of business is election of chair for 2020 Board of Health. We will now consider the item. Are there any nominations for chair of the Board of Health? Yes, Councillor Wong-Tam?
Yes, thank you very much. I'd like to nominate Councillor Cressy for the position of chair of Board of Health.
Okay, so Director Wong-Tam has nominated Director Cressy. Director Cressy, do you accept the nomination? So I'm calling nominations a second time. Are there any further nominations? I'm calling nominations a third and final time. Are there any further nominations? As there are no further nominations, the nominations are now closed. Director Cressy is the only nominee, so I declare Director Cressy elected as Chair of the Board of Health for a term of office starting January 13th, 2020 and ending December 31st, 2020 and until a successor is appointed. I will now ask Director Cressy to assume the chair in order to conduct the election for Vice Chair.
Well, thank you kindly, and thank you to Director Wong-Tam for that. We will now proceed with a run-through of the agenda. We're going to go through the whole orange sheets before dealing with each item. So on the orange sheets, as we go through, item 13.2, election of a vice chair for 2020 Board of Health. That will be held down as we have to deal with it. Item HL 13.3, promoting and ensuring accountability at Toronto Public Health. We have speakers on that, so that will be held. Item HL 13.4, 2019, a year in review of Toronto Public Health. Would anybody like to hold that down? Okay, seeing none.
Move.
Director Layton is moving to receive the report. All those in favor, opposed if any, that carries. Item HL 13.5, housing approaches that support health. There is speakers, so that will be held down. Item HL 13.6, Ministry of Health's consultation on changes to public health in Ontario. I would like to hold, there's a presentation, so that will be held down. Item HL 13.7, mobile dental clinic 3-month pilot on alternate service delivery model. I would like to hold that down. Item HL 13.8, subway health impact study. There are speakers. And I believe there is one new business item that needs to be added to the agenda. It comes from Director Layton concerning gambling. Do we need a motion to add that to the agenda? So I'd like to move a motion to add that to the agenda. Moved by Director Layton. All those in favor, opposed if any, that carries. Would that like to be held down, or do we want? Would people like to move the item here?
I'm happy to move the item. I think it's pretty self-explanatory. Everyone should have been circulated it. So there's a lack of data about the impact of additional gambling at Woodbine on residents of the City of Toronto, and I think we need to bring this into public health's hands for a report.
So is there any desire to hold that down for questions or comments, or are people comfortable moving with the report? Okay. So moving the recommendations in the letter from Director Layton. All those in favor, opposed if any, that carries. Okay, we'll now proceed back to the formal agenda. Item HL 13.2, election of a vice chair for 2020 Board of Health. Are there any nominations for vice chair of the Board of Health? And in return, I would like to also nominate Director Wong-Tam. Director Wong-Tam, you have been nominated. Do you accept the nomination?
I accept, Chair.
Okay. I'm calling nominations a second time. Are there any further nominations? Okay, and I'm calling nominations a third and final time. Are there any further nominations? Seeing none. As there are no further nominations and the nominations are now closed, Director Wong Tam is the only nominee, so I declare Director Wong Tam as re-elected as Vice Chair of the Board of Health for a term of office starting January 13, 2020 and ending December 31st, 2020. Congratulations. Okay. So, carrying right along, we'll move into item HL 13.3, promoting and ensuring accountability at Toronto Public Health. There are two speakers. Our first speaker is Derek Moran. Derek, you know the drill. There's a clock on my right. You'll have 5 minutes, and you can begin when you're ready.
I just want to point out that clapping is allowed here after all. I just want to say by me speaking at this meeting, this shall not be deemed to be in any way my consent expressed or implied. In doing so is fraud. God bless Her Majesty the Queen, and long live Her Majesty the Queen. Let the record show I do not consent to the unconstitutional searches violating Section 8 of the Constitution Act 1982 that are currently taking place here at Toronto City Hall, as the province has never given the City of Toronto express statutory authority to do this. Now, I guess, kind of expecting the Auditor General would actually be here for this item, so I guess we'll just go along with this. So in this report, it says Toronto Public Health has been selected along with other public health units to participate in 3 significant value for money audits: food safety inspection program audit, chronic disease prevention audit, immunization audit. Now, something that the Auditor General said at Audit Committee before that I never thought I'd hear someone at the City of Toronto here say, and I made a meme out of it. You can see there, she said, "My first statement is always be clear on the law." So I just wanted to refresh her memory that as part, she's also a lawyer, as part of the oath she took to the Law Society. Amongst other things, it says, "I shall not pervert the law." I don't think she will. It's just the City of Toronto perverts the law all the time. And "I shall seek to improve the administration of justice." I just want to point out justice in Black's Law Dictionary, 9th edition, is defined as the fair and proper administration of laws. Because in regards to ISPA, the Immunization School Pupils Act, there's something about acts and statutes this place doesn't really, probably isn't aware of. So,
Derek, can I just ask you to keep your comments to the item we're dealing with? We're dealing with the audit item.
yeah, can I just get you to respect my freedom of expression, which is guaranteed in Section 2B of the Constitution?
Derek, we've done. Derek,
This place is taking Premier Ford to court on the basis that he violated freedom of expression. And because of it, you're not able to provide effective representation. You're interrupting me, okay?
you just keep your remarks to the item that you're disputing on. Thank you.
The item in the report talks about the Immunization Act. Speaking on something in the report. So, the in personam admiralty jurisdiction of the federal court paper, which was written by Chief Justice of the Court of Appeal for Ontario, George Strathy, says, "Canadian maritime law is that body of law defined in Section 2 of the Federal Court Act. That law was the maritime law of England, as it has been incorporated into Canadian law, and it is not the law of any province of Canada." Okay, we got that? So here's what it says in Tropwood AG versus Savacca, Wire, and Nail, 1979, Supreme Court of Canada. "Canadian maritime law means the law that was administered by the Exchequer Court of Canada on its admiralty side by virtue of the Admiralty Act or any other statute." I think we'd all agree that ISPA is a statute, right? "Or that would have been so administered if the court had on its admiralty side unlimited jurisdiction in relation to maritime and admiralty matters. The reference to the Admiralty Act is undoubtedly to the Act of 1934, but the Admiralty Act of 1891, although it was repealed, may certainly be considered as any other statute, by virtue of which the law was administered by the Exchequer Court on its admiralty side." ISPA, Immunization School People's Act, any other statute. So what exactly is the law? Well, I got a response back from my former MPP's office about this. "Hello, Derek. I've been in touch with the Attorney General's office with regards to your question. The answer is that Ontario does not have a civil code like Quebec. We have rules of civil procedure, but they deal with procedural matters only, not the substantive law. Ontario is a common law jurisdiction, and we rely on the common law, not a code. Please feel free to contact us if you have more questions in the future, and if you guys are interested. My MPP at the time, it says there, was Mike Cole. So he knows what the law is. So I just want to point out, ISPA, maritime law, the law of the water, that applies to crew members on somebody else's vessel. In reality, we live in a common law jurisdiction where the rules of equity apply also. That's section 96.1 of the Courts of Justice Act, where we live on dry land. Do you see how the two do not jive? You cannot force maritime rules upon us when we're not crew members on your vessel. So R versus Dome, 1996, Ontario Court of Appeal said, the Charter applies directly to government action, section 32.1, and any government action is of no force and effect to the extent that it is inconsistent with the Constitution Act 1982, section 52.
Thank you, Derek.
Yeah, but you interrupted me, okay? I'm just going to finish up this one.
I'm just going to give you one last sentence. Thank you.
I need to. A legislative enactment which is unconstitutional is akin to a judicial order made without jurisdiction. Both are made without authority, just as an accused can challenge the jurisdiction of the court to make the order the accused is alleged to have breached. That accused can also challenge the legislature's constitutional jurisdiction to enact the law the accused is alleged to have breached.
Thank you very much. Are there any questions for Derek? Seeing none. Thank you very much. Our next speaker on this item is Gary Thompson. Is Gary here? Welcome, Gary. You bet. Gary, you'll have 5 minutes, and we are dealing with an item here on ensuring accountability at Toronto Public Health.
That's right. Accountability.
So, Gary, just to say, we don't have anything related to overdose on this item right here. This is an item on accountability in the auditing process.
In accordance with the ministry, and this is from the Board of Health background, quote, paragraph 1, in accordance with the ministry's published standards, protocols, and guidelines using provincial funding, which comes from the taxpayer. And then item 7, public health modernization, paragraph, page 1, second paragraph. We clearly heard and responded to the need for more extensive consultations across the province on how best to move forward. Page 2, first paragraph. The rise in unprecedented emergencies such as opioids. Clearly, Ministry of Health has not moved forward on the overdose protocol, which increases morbidity and mortality. Anyone in need of respiratory assist.
Gary, that's item number 7.
That's right.
Okay, so if you'd like to depute, this item we're dealing with is the audit process. So if you could keep your remarks to the item in front of us, please.
Yeah, I'm worried about the taxpayers spending a needless, untold millions of dollars, so many left with permanent brain damage, oxygen deprivation. You've taught millions of people. It all started here in September 2011, and it's been going across the country ever since. Taught millions of people all the signs of respiratory emergency, deny rescue breathing, give chest compressions to a beating heart, and they're doing it. So I'm just wondering about accountability. Who's accountable? Is anybody going to be held accountable? Here's a letter from the Executive Director at Health Canada. Explaining that the different provinces have different protocols. Why is that? And humankind is not about. I'll quote you the Bible. Genesis 2:7, and God breathed the breath of life into humankind. John 20:22, and Jesus breathed upon his disciples. When you crucify someone, they suffocate to death.
Gary, could I ask you, we're dealing with an item on audits. So if you could keep your comments to the item related to the audit process, please.
Yeah, I'm wondering why you haven't been audited all the money that the taxpayer is losing needlessly.
Thank you.
Why haven't you audited yourself? Aren't you concerned for your own lives? suffer an injury or illness, they put you comatose and people are eagerly going to start pounding on your chest? You're not worried, eh? You're worried about being sued, maybe? There was a coroner's inquest. Dr. Elaine Davila was there. Jury's verdict was, do not deny risky breathing from anyone.
Thank you very much. Are there any questions for Gary? Seeing none, thank you very much, Gary. Are there any other speakers to this item? Okay, seeing none, we have a report in front of us. Would somebody like to move the recommendation in the report to receive it? Moved by Director Wong-Tam. All those in favor? Opposed, if any? That carries. Just before we go on to item HL 13.5, we do have to confirm the minutes from our meeting of 2019. Director Perks moved confirmation of the minutes. All those in favor? Opposed, if any? That carries. Thank you. So we dealt with item 13.4 already. So item 13.5, housing approaches that support health. We have a public speaker on this. Derek, you're registered to speak. Derek, you'll have 5 minutes.
I just want to point out, this is part of an affidavit that was admitted into the record by Justice Kavanaugh when Dion Rene took the police board to court. This is a City of Toronto lawyer telling then Councillor Mamalidi that basically when people come to speaker, they can talk about whatever they want. I just want to acknowledge Councillor Carroll for alluding to something I said at special governance recently, that nowhere in Toronto City Council procedures is there a rule that says people who go to speak at City of Toronto public meetings can't ask questions of their public servants. So in this report it says, recommendations reinforce the need for federal and provincial funding to allow the City of Toronto to act on its commitment to increase housing options for Torontonians, in particular, housing for vulnerable populations. Now, I'm just about to read a bunch of case law on housing, so I mean, if you guys want to check your phones or computers, I won't know any different. Mass versus Ontario, Ministry of Community and Social Services, 1996, Ontario Superior Court, Divisional Court said that whatever the outer limits of the concept of security of the person may be, it must at least involve having adequate food and shelter for physical survival. Although the question of economic rights fundamental to survival is an open one in the Supreme Court of Canada, it has been considered by courts below that level. In a number of the above decisions denying violation of Section 7, the courts have approved statements made by Professor Peter Hogg in his Constitutional Law of Canada. There, Professor Hogg considered the argument that security of the person in Section 7 included the economic capacity to satisfy basic human needs, like housing. He considered the possible role of the courts in dealing with such an argument. LeGroux versus Pitt, 2008, Ontario Superior Court. In Yin versus Lewin, Justice Rook also said, again referring to Hogg as authority, moreover, the right to security of the person under Section 7 does not include economic security, except perhaps to the extent of economic capacity to satisfy basic human needs, again, like housing. Singh versus Minister of Employment and Immigration, 1985, Supreme Court of Canada. Like liberty, the phrase security of the person is capable of a broad range of meaning. The phrase security of the person is found in Section 1A of the Canadian Bill of Rights, and its interpretation in that context might have assisted us in its proper interpretation under the Charter. Unfortunately, no clear meaning of the words emerges from the case law, although the phrase receives some mention in such cases as Morgentaler versus the Queen, Kerr versus the Queen, and R versus Barry. The Law Reform Commission, in its working paper number 26, Medical Treatment and Criminal Law 1980, suggested at paragraph 6 that the right to security of the person means not only protection of one's physical integrity, but the provision of necessaries for its support. The Commission went on to describe the provisions of necessaries in terms of Article 25, paragraph 1 of the Universal Declaration of Human Rights, which reads, everyone has the right to a standard of living adequate for the health and well-being of himself and of his family, including food, clothing, housing. If housing's a right, like, where do we ever get it into our heads that we had to pay for it? If it's a right, we shouldn't have to pay for it to begin with. and medical care and necessary social services, and the right to security in the event of unemployment, sickness, disability, widowhood, old age, or other lack of livelihood in circumstances beyond his control. Commentators have advocated the adoption of a similarly broad conception of security of the person in interpretation of Section 7 of the Charter. Reference regarding Sections 193 and 195.11C of the Criminal Code, Manitoba 1990, Supreme Court of Canada. In order to give Section 7 that interpretation, security of the person must be interpreted to mean the economic capacity to satisfy basic human needs, like housing, that is, to earn a living. Nowhere in Section 7 is there reference to property rights, and that omission is, in my opinion, significant. It should be noted that the court expressly stated that it was not deciding that Section 7 could not apply to any interest which has an economic, commercial, or property component. Another case from British Columbia, Whitbread versus Wally, 1988, BC Court of Appeal, also dealt generally with the question of economic interests in Section 7 of the Charter. Associate Justice McLaughlin, as she then was, speaking for the court, held at page 213 that purely economic claims are not within the purview of Section 7 of the Charter, although she did add the caution that she was not asserting that Section 7 could never include an interest with an economic component. The problem with that is that if you ask your politicians, your so-called trustees, how to use the security of the person to pay for the cost of housing, they won't tell you, which is you're just concealing information.
So those are
Concealing information
those
from
are
you,
your
which
5
is
minutes.
fraud.
Thank
Which
you,
is
Darren.
fraud. Concealing information from you is fraud.
Are there any questions for the speaker? Okay, seeing none, thank you very
I
much.
didn't know this place was so much fun.
Thank you. All right, are there any other speakers on this item? Okay, seeing none, we're going to move this into committee. Questions of staff? I have a couple, just very briefly. Do we, and I'll direct this to, I see we have staff here from Shelter Support and Housing Administration as well. So to our MOH or from Shelter Support and Housing Administration, does the City of Toronto have a target for how many new units of supportive housing to build?
Yes, through the chair, we do. That number is 18,000 over 10 years.
18,000 over 10 years. And is that because there is a waiting list for supportive housing?
There is a waiting list for supportive housing, for social housing. Yes.
Do we know what that waiting list is?
The wait list for supportive housing is growing to 8,000 plus people at this time.
Okay. So the City of Toronto has a target to build 18,000 units, which I see is referenced in the Housing TO action plan we're dealing with here. Is there a plan for the City of Toronto to build supportive housing units or a target to build them?
So through the chair, we are going to be reporting back with our colleagues in the Housing Secretariat to the Housing and Planning Committee in February the 12th. And within that report, we'll have more specifics regarding a target of 600 units of supportive housing to be built this year.
So 600 units, so each year for the City of Toronto to create 600 units. You're reporting, there's a report coming to Planning and Housing in February on that.
That's right.
Okay, those are all my questions. Yes, Director Mulligan.
I have a question for the Medical Officer of Health. Can you clarify the role of Toronto Public Health in providing services in public housing or funding services related to public housing?
So through the chair, thank you for the question. So again, we're a population health service, right? And we work in public health. So our areas tend to be more around, first and foremost, population health assessment and actually talking about and appreciating and understanding the health impacts of underhousing and homelessness in respect of our population. So I would say first and foremost, that's where we are involved in what I would characterize the diagnosis. We also work quite actively with our shelter support and housing colleagues, particularly around infection prevention and control aspects within the context of congregate settings. And we have a long and established history working with our partners there. We do have some other teams with community development officers that do some very specific work with particular populations, but much of the service that's provided is through our colleagues at SSHA and through community agencies as well, but that gives you a bit of a high-level overview.
Any other questions? Director Layton.
Thank you very much. So our goal is 18,000 over the next 10 years. How many of these supportive housing units have been funded by the federal or provincial government in the last 10 years?
So through the chair, I don't have a number for you over the last 10 years. I can say of the target that have been established, there's no, concrete funding on the table at this point other than the national housing strategy that the federal government would have in play.
So we don't currently have any funding on the table for the last, or for the target that's set. Any idea how many we built or opened last year of supportive housing units?
I don't have that for you right at the top of my fingers here, but I could report back to you.
Was it anywhere close to 1,800?
No.
Okay, thank you.
Okay, thank you. Director Wong-Tam?
Yes, following up on Director Mulligan's question regarding public health responsibility, if it is not the responsibility of public health to provide on-site supports to the tenant population who needs supportive, the additional wraparound supports, whose responsibility is it, and what order of government should be funding it?
So through the chair, when we talk about supportive housing and we're talking about healthcare supports in particular, that would fall under the purview of the ministry. So a number of those supports are indeed healthcare related. Let me be very clear about that. Hence, I would see the provincial government being the appropriate partner with whom to follow up.
And so that would include mental health services in sort of social housing.
Through the chair, when we talk about mental health services, often we are talking about mental health care and treatment and related resources in respect of mental illness. So yes, it is within the purview of the provincial government, most notably, I would say, the Ministry of Health.
And because the Ministry of Health themselves don't deliver the service on the front lines, they would be funding organizations that are community-based, mental health oriented. They would be funding the Ontario mental health hospitals such as CAMH. What's their responsibility when the money comes from the Ministry of Health provincially? Which organization should be in the physical buildings providing contact direct service to those social tenants?
So through the chair, there are a number of different agencies that provide those services. So, we are actually in a what I would characterize as a bit of a period of transformation and flux within healthcare. So what happens is that we have, very briefly, the Ministry of Health, who in turn, until recently, has funded the local health integration networks, who are in turn responsible for flowing funds to community agencies. That system is in flux, for lack of a better term. We used to have 14 local health integration networks. We're now down to, I believe it's 5 regional offices, all run under Ontario Health. But suffice it to say that the funding for community agencies that deliver those kinds of healthcare services in the community does come, at least in part, through the Ministry of Health. I imagine that some of them get some funding through other ministries or other routes as well. But I would also point out that there is home care that has traditionally been run through the CCACs, which were community care agencies that have traditionally been under the purview of those local health integration networks. And again, that's all rather very much in transformation and flux right now. But that's where the funding has gone through.
And for tenants who are in social housing that require supports around addiction and treatments and substance use, whose responsibility would that be?
So through the chair, that is also the healthcare system. And I would suggest to you that based on my knowledge, there is actually not very much that happens within the context of housing. There is a healthcare system that actually requires that people go to healthcare facilities to make avail of those services.
And finally, because recommendation 2 says that we should be urging the federal and provincial governments to increase funding to community-based organizations, healthcare providers, and so forth, what's the role of the federal government so far? Because you've highlighted a lot of what the province is supposed to do. What's the federal government supposed to do?
Through the chair, I think the federal government has a number of different roles to play here, certainly with respect to the national housing strategy and outlining a framework in which these services can be so you have housing and services considered as part and parcel. I think when it comes to issues around managing substance use and challenges related to substance use. The federal government certainly has some purview over legislation that has to do with the Controlled Drugs and Substances Act. And I think there are certain provisions that they can make that facilitate the ability of service providers to provide service.
Thank you very much.
Thank you. Are there to speak? All right, I'm going to put myself on the list, and if I could move an amendment, which is, if it can be placed on the screen, to request the medical officer of health in consultation with the deputy city manager and GM of our shelter support and housing division and the housing secretariat to report to the April meeting with details of the city's new plan to create 600 supportive housing units every year. So let me just walk through that a bit. As the report spoke to, on every rung of the housing ladder, people are stuck. So for the 8,000 people within our homeless population, if they have access to a shelter, they're often stuck without being able to exit the shelter. For the 15,000 people on the waiting list for supportive housing, there aren't units to get to. For the 181,000 people on the waiting list for subsidized affordable housing, that list is getting longer, not shorter, and we have an exceptionally strained rental housing market with increased evictions and renovictions driving people down the ladder. And so housing writ large affects the health of Torontonians, and I'm grateful that our medical officer of health is continuing to bring forward reports on this matter. Supportive housing is one critical piece, and it's a critical piece where I think Toronto Public Health has a key role to play, both in terms of advice to give and perhaps involvement in it. And so 2 years ago, the City of Toronto set a target. We're going to build 1,800 supportive housing units a year for 10 years. We have not been meeting that target, but we set a target. 2 months ago, City Council directed city staff to come up with a plan to create 600 units, 1/3 of those 1,800 per year, for the city to come up with a plan to create 600 units a year, every year starting in 2020. That plan will be coming to the Planning and Housing Committee here at the city in February. I think it's important that this board considers that plan and considers any role we might play and advice we might provide or recommendations as well. And so that's the impetus behind this. So in April, we will be looking at the city's new plan to create these units on an annual basis. And I hope it's a great plan. But I'm looking forward to the medical officer of health giving us her advice on it. Those are all my comments. Are there any other speakers? Okay. Question or speaking?
Speaking.
Speaking, yes, Kate.
Yeah, I want to speak in support of this motion and to suggest that part of the role of assessment could be excuse me, for Toronto Public Health to include health assessment as the City of Toronto takes on building of supportive and affordable housing. That assessment of health impacts and health systems costs and savings should be an important consideration.
Thank you. Any other speakers? Okay, seeing none, can we take this, it was to receive his report, so we just moved the amendment, is that correct? All right, so the amendment is on the screen. And adopt as amended. All those in favor? Oh.
I was just in conversation with the medical officer of health. I think because there's a report that deals with this matter going to planning and housing, what I'd like to do is take the staff report that's going to be generated from, I believe, Gord's office or the housing secretariat, direct it to the medical officer of health so that she can perhaps put the health lens over that report and bring it back to this committee, so as opposed to writing a separate report, just to set up some expectations. So you'll still get the outcome. You'll still have the chance to deliberate this item here, especially with medical officer of health's comments over the housing report.
I think that is the intention. It's not to create a whole new plan. It is to bring forward that report to the April meeting with the medical officer of health's advice on it.
Very good. So just to clarify, so it's not to necessarily write a whole new report.
Correct.
Thank you.
Okay.
Okay.
Are you satisfied? That is the intent. If you're satisfied
Yes,
with
thank
those
you.
questions, clarification? Okay.
Thank you.
So then the amendment, we'll take it as a package, amendment and the motion as amended. All those in favor? Opposed, if any? That carries. Thank you. Okay, that takes us on to item HL 13.6, everybody's favorite topic, Ministry of Health's consultation on changes to public health in Ontario. And we have a staff presentation on this. And so, Gail, I will turn it over to you whenever you're ready.
Great, thank you. Good morning. This is a presentation on the Ministry of Health's consultation on public health. In November of 2019, the Ministry of Health announced a consultation with stakeholders to inform their view of public health. At the same time, the Ministry released a report for consultation called Public Health Modernization. This presentation is to update you on the consultation and to provide information for consideration in a response. The consultation process kicked off in November and lasts till approximately February of this year. It consists of two parts. First, an in-person meeting that's being held across the province with various health units, boards, and their senior staff. Our meeting is scheduled for February 10th. The other part of the consultation is a survey. It's online, 21 questions, and it's open until February 10th. To gather information for the survey, we held an all-day workshop in December, to which all management and frontline staff were invited. We've taken the information from that good, hearty discussion and summarized it, along with an internal staff survey that includes all 21 questions that our staff can give input to, and then we can summarize for our response. Because the survey is open, we've encouraged our staff to respond as teams, to respond through their professional associations, and to respond as individuals. So essentially, that's the consultation as we know it now. There are public meetings, ours being February 10th, and there's an online survey. To respond to the survey, it's useful to look at previous reports that have reviewed the function of public health. There are many. I've listed a few here, some of which will be familiar to you because they came after major events such as SARS and H1N1. The titles are revealing. They all speak to some form of revitalization or renewal, and they all have a call to action to strengthen public health. A review of these reports shows that the recommendations boil down into two main areas. The first is public health as a system, not as a narrow delivery agent of a small number of programs, but a system unto itself. The second set of recommendations all speak to characteristics or principles that will strengthen public health as a system. So in the next few slides, I'll go through how these reports, written by public health leaders over the years, characterize public health as a system. It's helpful to look at public health in comparison to the other very large system in health, the healthcare system, which Dr. DeVilla was speaking to earlier, and to understand how we are distinct and different, but how individuals do flow between these two systems. So for example, an individual in the community may have contracted tuberculosis and been picked up through, as Dr. DeVilla was mentioning, our assessment and surveillance function, and then move into care in an institution. So we would then be working with the individuals in the institution to transfer that individual, and they may come back out into the community and be monitored by our staff when they leave a healthcare institution with a condition such as tuberculosis and need to be monitored in the community. But when you look at the list of functions on the left-hand side there, the movement of individuals with a healthcare issue really pertains to health protection, mostly the communicable disease programming, some dental, and some other programs. But for the most part, when we're dealing with individuals, we're dealing with bullet 5, health protection. But there are many other functions listed there that we do, and we are always concerned not with just individuals, but with whole populations, with subpopulations such as schools, and we're concerned with them throughout their entire lifetime, and we do many different functions and interventions rather than a more narrow function that healthcare as a system provides. So that's the first message that the leaders in public health brought forward in these reports. And that is that we have a broad range of functions that we need to provide as a system. The second major theme that they brought forward was that we work with a broad range of organizations. And by work with, I mean in a formal sense. We can't do our work unless we're in a formal relationship and moving information or understanding contexts with particular organizations. I mention this because the survey asks quite specifically how we can work more closely with healthcare or social services. The authors of these reports that I reviewed would say we are open to working more closely with healthcare and social services, but we also need to continue to find ways to work even more closely with the organizations and departments that are listed here. So clearly you've seen through the years many reports that have come forward based on our work with municipal licensing and standards, with planning and transportation to build healthy, walkable communities. We're currently working with parks on vaping and tobacco bylaw work, and we consider that to be very important work that has to be done in close partnership with those particular departments, but also with community organizations that have listed there who sometimes are the third-party deliverers of our programs. So sometimes we're funding community organizations to provide nicotine replacement therapy or smoking cessation in high-risk communities. We also are legislated to work with organizations such as daycare. So that's the second big theme, that there is a wide variety of organizations we need to work with. The next theme that comes out from these reports, it's helpful to understand how our particular interventions are different than the healthcare system, where again the focus is an individual who brings himself in need of care, is assessed, diagnosed, treated, or counseled. Whereas in contrast, if, for example, an individual is seeking support through public health, they sometimes are coming from healthcare. So say we have an individual who's been diagnosed with a heart condition and needs to quit smoking. They would have that assessment done and go back out into the community, but when they come into the community, we would be providing support such as nicotine replacement therapy or smoking cessation, which fits under the skill development intervention, through third-party community organizations. And if this was 15 years ago, we would be working hard to create a smoke-free environment in that individual's workplace and in all the public spaces that they go to. And that's because our work is based on assessment, which means research, and we know the research supports successful smoking cessation happens when you have supported environments that are smoke-free, both workplace and public. And then because we are concerned with people throughout their lifetime, we would also be reaching out to family members, such as the children in that family, to give them information in schools, to make sure that schools' property are smoke-free through our inspection process, and to make sure that retail advertising of tobacco is within the legislation. So you start to see how we do a range of activities for any one issue to make sure that the support is in place throughout a whole lifespan. For practitioners to do that type of work, the reports speak to a need for practitioners to be subject matter experts, but also to be experts at working with local partners in the community and to understand data as it evolves in the community. And finally, a characteristic of a health system is that there's public accountability or public reporting, different than a hospital board that is not required to have open public board meetings. This final area that I've depicted here relates to accountability. So the survey asks questions about our roles, provincial role, the local field role, and the role of Public Health Ontario. The reports don't spend a lot of time on roles. They feel that they're articulated clearly now, but they do speak to the challenge of both individual accountability for our role, as well as accountability that we have for the whole system to the public. So what they mean by that is that when there is a problem, it isn't enough for us as the field to just, for example, with vaping, report that we've done an assessment, we see vaping increase, and we're going to provide a local bylaw. You'll recall that in the report we brought forward about vaping, we also brought forward the evidence around availability, the appealing nature of flavored vaping products, as well as advertising. So again, we're bringing forward the research and we're bringing the accountability, in that case, to the province and the feds. So the point being, as expressed in the last couple of bullets, because local context and an emerging issue like vaping are important to being effective, we need to be working in a mutual respectful working relationship with the province and a shared responsibility for the public's health. It would not have been, we would not be accountable either individually or as a system if we had just brought forward a report that focused on a bylaw. The other half of this presentation will be about characteristics of a strong, or principles of a strong public health system that these leaders reflected on and had brought forward in these reports, but that are very much similar in nature. The first one is, again, this idea that we are a set of interrelated, interdependent players, both the province and the field, who have to work together towards a common goal, and in fact, who are accountable to the public. One of the reports speaks to it as a playing field, a team that has both offense and defense, that has to pass the ball, but it really, at the end of the day, is accountable to the public for how we work well together. And we certainly saw, in particular in the SARS report, how we needed to do that work more cooperatively and set up systems to support us. So that's what the next two slides get at. If we are to work as a team, there needs to be, if you will, a game plan that is developed jointly. We can strengthen this area by looking at the work that's done in Quebec, where instead of having standards that then are implemented by the province and a kind of an us and them relationship, the provincial medical officer of health, chief medical officer of health, joins with leaders from each of the major health unit areas and develops a 10-year plan. So if it was 15 years ago, this plan would include the need to create smoke-free workplaces, bylaws for smoke-free public places, and then eventually the smoke-free provincial legislation as an example, along with all the other areas that we have jurisdiction over. But you can see how it doesn't make sense to develop individual plans across the province, but for some areas, such as tuberculosis, we would have individual priorities because tuberculosis is an issue for Ottawa and Toronto, not so much for rural Ontario, Huron County, or Grey Bruce. So there needs to be a balance between individual context, attention paid to priorities, as well as priorities that are best done across the province and in a coordinated way. Interestingly, in Quebec, after they do this 10-year plan, the individual, they call them regions there, in our case it would be the health unit areas, develop a local response, again getting at what in their context is the best way to apply. In our case, vaping would be an example, where we've got a lot of vaping outlets in a more rural area. They wouldn't have as many, but they may have an underground market. So there needs to be localization, but there's a commitment to implement that plan and resources are matched to it. So that's the what. Then similarly for the how, we need a mechanism to come together to plan when we are going to have a particular issue researched so that we know the evidence and we're not doing it in duplication, but we need a mechanism to organize that. We have this now to a certain extent for some issues. It certainly could be strengthened, but we again need to strike that balance between local adaptation and when we want to work together as a province. So a local health unit area may want to pilot a particular new initiative for scaling up in the province, or we may, as I mentioned with tobacco legislation, may want to have individual health departments work together to create, as it was done with tobacco, local policy bylaws and then work towards a provincial change. So there's a pattern there where we can work both independently and collectively. Stakeholders was an area that I mentioned before or in this presentation that they emphasize that they are part of how we do our work, not just a casual partner. And sufficient workforce who are able to do this local customization, and then knowledge to practice function are two other areas that the reports mentioned for a strong public health system. The final areas are quite clear in terms of the experience that you've had here at this board, one being stable, predictable funding, and the other, this concept of both independent accountability as a field or as a province, but also joint accountability for how well we work together to protect and promote the public's health. So in summary, all of these previous reports had envisioned some form of revitalization. Some of the recommendations have been implemented. So we have two major public health agencies now that we didn't have before SARS, one being Public Health Ontario, the provincial agency, and Public Health Agency of Canada, which is the Canadian equivalent of the Centers for Disease Control in the US. So those are good accomplishments based on these reports that were previously written. This public consultation with the province offers us the opportunity to realize even more of these recommendations that were identified by leaders in the field. The most important message, though, is to recognize public health as a system with unique features, some of which no one else does, and that need to be implemented for the delivery of population health going forward in a way that revitalizes the public health sector. And I'll close there. Eileen may have some closing comments that she wants to make.
So yes, if I may just wrap up the presentation. Thank you, Gail, for providing that presentation, and I hope it has provided members of the board with some points and principles and thoughts for consideration as the Ministry of Health embarks on its consultation process. Just to reiterate a couple of points that were made within the presentation itself, The province is currently holding an open public consultation process in respect of public health modernization. This is the process that they've undertaken, and that survey is in fact open to all members of the public. And to our knowledge, what has been put out there is that that survey is open until the 10th of February. We are also in conversation with the province right now. We understand that they're working towards a February 10th consultation date with the City of Toronto. Just to be clear, their modernization process, as the province has described it, is not just with respect to public health. They are also doing a consultation process around the province in respect of emergency health services. So the province is currently proposing to hold a in-person consultation session with the City of Toronto on February 10th, half of the day covering public health, and half of the day covering emergency health services or paramedics. So that's our understanding of the consultation. We're still working through some of the details or waiting to hear with respect to what the province has in mind for that consultation session. But we're certainly, once we have something a little more confirmed, we will be sharing that, or presumably the ministry will, with members of the board so that your active participation can be solicited. So with that, I'll turn it to you, Mr. Chair.
Thank you. Questions of staff? Yes, Director Donaldson.
Thanks, through you, Chair. Thank you for this great presentation. On page 12, you talk about the Quebec model. So can you just help me understand the differences between Quebec and Ontario a little bit more? So I think what I heard you say is that in Ontario, we have legislated standards, and in Quebec, it's a little bit different in that they're not legislated and they're co-developed. Is that correct?
Sure, through the chair. The current system in Ontario has public health standards, and they're developed, I've been on some of their committees, they're developed together with the field, but they are then left to local interpretation and customizing by the field. And in the case of something like tobacco legislation, and before that the bylaws, and even before that smoke-free policies in workplaces, you can see where there's strength in having a coordinated approach across the province. So that did happen with tobacco, and it happened in part because of leaders in the province and leaders locally who came together, but it was more ad hoc and less formal. Whereas in Quebec, as I understand their system, they do have a similar system of an agreed set of goals or standards, but they also have this approach of a 10-year plan where they look at particular issues. And there are many, many issues. I just chose tobacco because it's simple to understand. Tobacco 15 years ago needed work to create the current bylaws and tobacco legislation that we have. Vaping is in the same situation now, where we need to work as a system, and where this concept of joint accountability comes in so firmly. So I am suggesting that rather than having an ad hoc approach issue by issue with tobacco or with a communicable disease, that we create a system where we formally create a plan for a period of time, commit to local implementation, and then roll it out. So it's like in addition to the standards.
Just as a follow-up, is there, so Quebec does a 10-year provincial plan. Is there funding that flows alongside that 10-year plan? How does the funding model work in Quebec?
To my knowledge, there is an additional funding. It'd be part and parcel of the budget that's there.
Okay. And back to the Ontario public health standards, and because they exist in legislation, provincial legislation, and you said there is some local interpretation, is there the static nature of that? Does that impact Toronto Public Health's ability to be responsive on the ground?
So through the chair, the wording that's in the standards varies depending on the research for a particular issue. So sometimes we know exactly what the intervention needs to be, and there's a protocol very tightly written for it. It tends to exist in the clinical services such as communicable diseases or in dental. In others, the verbs that are used are broader, so it would be in collaboration with community groups ensure that X and Y happens. So there's a range of verbs, if you will, that are used. I don't think they limit us. I think they allow us to create that local customization.
Great. Thank you very much.
Thank you, Director Perks.
Thanks. I just want to make sure I understand the policy development or action development process you seem to be recommending. So you're saying have a province-wide plan, but customized locally. Is that? Yeah? So I have a question, concern about that. So one of the things that I think has been remarkable about Toronto Public Health is that on many issues, smoking included, the Toronto public health system has been able to advocate for things that the province has not yet taken on. You mentioned smoking, so I remember many years when the Toronto Board of Health was advocating for getting smoking out of bars and restaurants and workplaces well before the province considered it a problem. Similarly, the pesticide bylaw, actually the province actively was a problem when we were doing that. So do you see a role in the system you're advocating for local health units to generate issues that are not priorities province-wide?
So in short, yes. And I'm not suggesting this is the only way. I just think, really I'm reporting what the reports that reflected on how public health could function well suggested. There may be other ways to get there, but it would do exactly what you're suggesting. Locally, we have a role in surveillance and assessment, and when we're seeing something like vaping rates, or as you mentioned previously with tobacco, we have a responsibility to report and to look at the literature and see what is the most effective way to affect that. In the case of vaping, as I mentioned, one of the effective routes to go is to deal with availability, flavors, and advertising. Again, outside of our jurisdiction, but we certainly brought forward that recommendation. So I would say I'm in agreement with what you're proposing, because we have a role to reflect what we're seeing in the community and what we know works in the literature.
And that will be part of our feedback to the province as they do this consultation?
Through the chair, absolutely. And my expectation is that as they do this consultation and afford us that in-person half-day session, there will be no shortage of opportunity for members of the board to express that. In respect of that which is happening at the local level, the history that you talked about with respect to Toronto, I think what's interesting about that is that, yes, Toronto has always played a leadership role in that regard, and that has been augmented and been most successful in the province when it's Toronto and Waterloo and Peel and Durham and Ottawa. It's the local partners together that actually bring that real strength and that make for that change that needs to happen and has happened in the past at the province.
Thank you very much. Director Mulligan.
So thank you for the presentation. Thank you, Chair. I do have some questions around the issues for consideration with respect to the public health modernization paper, which is on page 4. There are a few things that are either asked about in the discussion paper issued by the province or that I think are important to the mandate of Toronto Public Health that aren't mentioned here. So one of them is health equity. I don't see this mentioned directly in the paper, and so I guess my first question would be, what is the role of local public health and the public health system in advancing health equity?
So through the chair, people who've heard me speak on what the role and objectives of public health are probably tired of hearing me say this, but I'm going to say it anyway. When I think about public health and when we think about that which we have to do here at Toronto, and I would say public health system writ large, we have 3 major objectives. The first is to improve the health status of the population. The second is to reduce disparities in the health status of the population. And the third is to prepare for and respond effectively to outbreaks and emergencies. So by definition, health equity has to be, it is part and parcel, it's in the DNA of public health, and it's one of our fundamental objectives. So it's throughout all aspects of public health.
Okay. Secondly, there are references to local decision-making and roles and to municipal decision-making and roles. Are these the same thing from the perspective of public health?
So I'm sorry, through the chair, where are you?
So for example, scale up locally developed interventions is one thing, or use local community networks to maximize health impacts. These are on page 4.
Yes, so through the chair, I think there are a couple of different things. So sometimes there are areas that are within the context of a given municipality. And for others of our partners, a local public health response is not exclusive to one particular municipality. It's a series of different municipalities working together. So it depends on context.
Another thing that isn't mentioned is the role of data integration and digital health. What should the role of public health be in ensuring, given the population health assessment role, that data can be shared across social services, health, care, public health, and so on?
So through the chair, an interesting question, and one that actually has a number of different nuances to it. And it all depends on which function we're talking about. There are some times where we need to actively share individual level information in order to best protect and promote the health of the population. There are other times when, in fact, all we need is aggregate data. Non-nominal aggregate data. So I don't think there's a one-size-fits-all solution there. I think we need to have a supportive technological environment that actually facilitates the ability of all partners, whether they're within the public health system or whether they're within the healthcare system, and for the interaction between those two systems, we need an environment that actually facilitates the ability for all of us to do our job, and what that looks like actually varies depending on which circumstance we're looking at.
My next question is about, there's a mention here of defining a formal working relationship between Ontario health teams, public health, and municipalities. And I noticed that the discussion paper asks particularly about deepening relationships with primary care. So can you tell me a little bit about what that role ought to look like from a public health perspective?
So through the chair, I don't think I have an exclusive purview over that. Certainly I have some influence. The Ontario health teams are very much in development. So I think, and each of them is taking its own unique character and role. I do believe that when we look at public health, there are particular areas where we need to have effective communication and interaction, particularly with primary care. In the case of, for example, work that has to do with individual communicable disease case management, we have an important role there. When we have emerging new infections, we have an important role there. Certainly in respect of immunization, we have important interactions that need to occur with primary care providers. And to a certain extent, in terms of having conversations around what is actually impacting on the health status of the population, new and emerging health issues, I think there's an important role to have. However, I do think it's important as well to distinguish that which is public health from that which is health care, primary care being one aspect of that. And there's much more we could speak to on this issue, but there is, I see them as complementary but not entirely similar roles, and there are certain areas where we need to have greater integration, and frankly some areas where our work may be quite separate from each other. I think as the Ontario health teams develop, the nature of our relationship that we would have as the local public health unit may be quite different from one to the next, depending on what the nature of the Ontario health team is.
I'll just ask one last question, if that's okay. With respect to, just going back to there's a mention, an explicit mention around Indigenous health and Francophone health in particular as two priority groups. So from the perspective of Toronto Public Health, would you support the principle of Indigenous health in Indigenous hands?
Through the chair, yes.
Thanks.
Thank you very much. Anybody else with questions? Director Wong-Tam.
Yes, just following up on the question around health equity, because it's not explicitly named in the report, and you did speak about the aggregate data, how do you actually pursue and achieve the outcome of health equity if we're not talking about disaggregated data?
So through the chair, it's not that all data is aggregate. We talked about data strategies and a data environment that actually supports the right data at the right level, depending on what the function is. So fundamentally, health equity is built in, and it's actually one of the core objectives of public health. If we improve health status of the population, but do so in a manner that actually increases disparity in health status, then frankly, I would have to tell you that we have failed, or we're not doing our job sufficiently. So I don't think, as I was in the previous answer I gave, there isn't a one-size-fits-all solution. It's a question of what issue are we trying to resolve? With whom do we need to partner and collaborate in order to effectively come to resolution on that issue? And therefore, what data do we need? And each of those situations will be different. We talked a lot about healthcare and the need to exchange particular information with healthcare providers, but it may be just as important to share information with, for example, our colleagues at SSHA, just as an example. So we need to think about a data system and an environment that actually, and technology that supports those different functions and the exchange of information at the appropriate level with the right partners.
And whose data system will we be relying upon? Whose responsibility is it to collect this data?
So through the chair, I think that this is part of the conversation that we're hoping to have with the province. Right now, when it comes to certain systems in public health, they are largely provided courtesy of the provincial government. And we are all beholden as local public health agencies to use their existing systems. They are not always the most flexible. They don't always provide all the functions that we're looking for, and I think that this is one of those issues where we have an opportunity to engage with our provincial partners to talk about the kinds of systems we need across the province and how we come up with systems and environments and legislation and regulations, et cetera, and technology that actually allows for the flexibility that we need to manage priorities that exist across the province, but in a way that respects the local context.
Just a quick pivot. The meeting with Toronto Public Health, and I'm assuming that this meeting is taking place with yourselves and other senior public health officials on February the 10th, and the chair. Oh, all of us.
Mm-hmm.
So this is the consultation, so the ministry's coming here.
So
Is that
to be
correct?
clear, through the chair, the details are still very much being worked out, and the province has held a few of these sessions already, and frankly, each one has been slightly different one from the next, because they're, I think, learning as they go along. And I think that's fair to say. So our understanding is that they would like to hold a local consultation here with the City of Toronto, and half of the day would be dedicated towards public health. My understanding as well is that the invitations would be extended to members of the Board of Health and senior city officials, including senior Toronto Public Health Management and senior city management, should they wish to attend.
So just to clarify logistically, will we be convening a special meeting of the Board of Health to actually do the consultation with the province?
So through the chair, my understanding is that in other jurisdictions, it has not been a special meeting of the Board of Health. It has been a meeting that has been hosted by the province to which they issue, or for which they issue the invitation. So it's their meeting, and they're issuing the invitations to those who have interest and purview over the issue.
And so just therefore, they will also be setting the agenda. They'll be going through their consultation survey with us.
So,
And not to put you
Yeah.
on the spot to answer questions that you don't have the answers to.
So through the chair, the province actually, so from what we understand with the other jurisdictions that have already had such meetings, there is a high-level agenda that provides an opportunity. They have a presentation. That's my understanding of the way these meetings have gone. The province provides a presentation, and then they have it sounds like a fairly open dialogue. People may ask, invitees, participants can ask questions of them, provide insights, make their comments in respect of the consultation paper, the presentation, or any other issues related to public health modernization as you see fit.
Okay, thank you.
Director Donaldson and then Director Perks.
Just to clarify, the survey, is it open to the public?
Through the chair, yes.
And to your knowledge, has the ministry committed to making public the results of the consultation and the survey?
To my knowledge, no.
And in terms of the trajectory of this project and the timing, has the ministry declared any intentions around when they expect it to be finished?
So through the chair, my understanding is that the survey itself, that public survey that's available online, is open until February the 10th. I don't know when their final consultation, in-person consultation with jurisdictions is. I do know that ours is currently, they're targeting February the 10th. And there may be dates after that. But beyond that, we really don't know what the wrap-up looks like. It sounds, as I have indicated, based on the conversation that we've had with other jurisdictions who've had their in-person consultation, it sounds like the process that the province is undertaking is rather fluid. They are adapting their presentation and/or the conversation as they go along.
Thank you.
Thank you. Director Perks.
Thank you. So I'm struggling with this. I mean, we're being asked to give ideas for how public health should be run in the province of Ontario, basically on 3 weeks' notice now. Right? I appreciate the province has done something, but we as the board are having this put in front of us for something that takes place on February 10th. I see that there have been some sit-down meetings with Toronto Public Health staff, and there's been an effort to try to build a body of thought there, but I don't see reflected in this report what was generated out of that. And I guess the step that I feel is missing, and I'm trying to figure out how we get that step, is an opportunity for some members of the Board of Health, or all of us, or some of us in small groups, to sit with some public health staff, or at least be given a piece of paper that says this is what public health staff have raised, these are the kinds of issues, and give us a chance to engage in it. And I'm wondering, is there any possibility of members of the board and Toronto Public Health staff to have a bit of a conversation before we provide that input on the 10th? I realize that's really fast, but even informally, there must be something. So I'm wondering, is this something that you can conceivably find an approach for?
So through the chair, I think this presentation was meant to be the beginning of that conversation, recognizing that it is January 13th. And this, I admit, is a very, very rapid process, right? The province came out with their paper towards the end of November. By then, as you know, we're starting to move into holiday season, and so we have some timing challenges for sure. But this was meant to be the opening salvo to a conversation. What I'm going to suggest is we're happy to put together, we are pulling together the information. Again, the staff session was held also not that long ago, as it turns out. So it does take some time to pull the information together and to summarize it into something that is actually that would be useful for you as a board to engage with. So very happy to do that and to start and to figure out what makes the most sense. We know how very busy your schedules are. How do we set this up so that you're able to engage in this meaningfully? Very happy to take that away and then communicate with members of the board offline to figure out what makes sense, because you all have very, very busy schedules. We know we've been trying to arrange a few other sessions that have presented some challenges.
Just as a thought, it doesn't need to be a formal meeting of the whole board. It may be 2 or 3 of us are available on a given Tuesday to sit down with some staff or whatever it takes, but let's not get constrained by trying to get a formal meeting with all of us together.
Of course. So through the chair, we just have to be mindful of the appropriateness and the rules of how the board should work, what constitutes a board meeting, and what's seen as appropriate. But we will take that offline. There are certain, as you know, certain standards that we have to uphold.
And if it's not a meeting with a quorum of board members, there are plenty of ways I've seen in engaging board members in the past on an informal basis.
Yeah, absolutely.
Thank you. Other questions? Okay, I have a few. So the province put forward, just So we're all completely on the same page. Province put forward a complete reorganization plan proposed last April.
Yes, sorry, that was a question.
In response to a lot of concern and opposition and organizing, that was reversed. Is that correct?
Largely.
Largely. Subsequent to that, the province appointed a special advisor.
That is correct.
They then released a discussion paper in late November.
That is correct.
There is a consultation process, but it seems like it is ad hoc and there is not every board and every public health unit having the same process. Is that correct?
There appears to be some difference, yes.
Okay. Has Toronto Public Health had any consultations with either the special advisor or the ministry on this process, on the actual reorg and this process?
Not to date.
Not today. So at our last meeting in December, we requested this report, which is in front of us, and we've requested this board a formal meeting with the special advisor and the province. So you've mentioned February 10th. Is that confirmed? Have they said that they are going to meet with the Board of Health on February 10th?
So I have had that verbally. They are looking for a contact. I just received notification on Friday that they're looking for a contact. I now have that contact for them to start to make arrangements. And what I have in writing is February 10th.
Okay.
They said they would like to start making arrangements.
Okay. And that will be for the Board of Health?
It is for it's for public health, and it is meant to be Board of Health and staff.
Okay. On the substance of what is being discussed here, so the discussion paper, and I've struggled in part, having read the discussion paper, read the report here, from public health staff and yourself to understand what are the risks? I mean, what is going well that is not reflected in the report that we need to ensure is carried forward, and where are the risks as evidenced in their early discussion paper?
So that's a hefty question, and I don't know that I can answer it within the time that you have. But suffice it to say that there are a number of issues that we see within the context of the report, the consultation paper, and one of the challenges that emanates, that Gail made in the presentation, is that public health is a system in and of itself, and it is separate but related to healthcare and other social service partners. The way the consultation paper presents things right now, it talks about local public health like it's its own island and that it's responsible for everything, when in fact we know that there is a provincial role, there is a federal role, there are municipal partners, there are community agencies that all contribute, and the concern that we have, if I had to put it in an overarching, overriding concern, is that the current paper does not view public health appropriately as a true system, of which local public health has a key role, but not the only role.
Yes, when I've read the discussion paper and our report, local governance I did not see within the discussion paper, and the importance of a locally responsive and organized body. I didn't see the principle of stable and predictable funding referenced. Others on the board have talked about the role of prevention and health promotion, the role of health equity. Those core tenets, as I see them, of an effective public health system, I don't see identified in their discussion paper. And so that's where I say, where are the areas that going into, so Toronto Public Health is in the process right now of preparing a response, is that correct?
That is correct.
So I'm curious, in Toronto Public Health preparing the response, what are the concerns and the things that must be considered that are not, that you're planning to bring forward?
So through you, Mr. Chair, if you look at the presentation, and actually when you look at our previous reports, the board actually has established responses and has positions that they've adopted in respect of public health. Stable and predictable funding. If you look on your slides, it's on slide 15, it's actually explicitly mentioned there, and we actually have mentioned that several times in the past. Happy to, hit it again, but that has been a fundamental, if I can call it a sine qua non. We've always felt that that was absolutely a must-have. Public accountability, I would say the variation on public accountability is actually local accountability. And that may not necessarily come through on this slide, but certainly with the combination of public accountability and the need to be tied to local community, to be aware of the local context and to actually be effective in the local context, I think local governance is part and parcel of that. But happy to hit some of those points again, although they have been, they're quite clear as our positions from the previous interactions with the provincial government.
Okay, thank you. Those are my questions. Any other questions? Okay, we'll move into speakers. To speak, Director Wong.
Thank you very much, Mr. Chair. So when I saw the report from the Medical Officer of Health with regard to this item, I thought the recommendation for the board was very passive. Because what I saw, Mr. Chair, you just circulate the motion amendment, because we got to communicate to the ministry, to this province, the government, the provincial government, because if they're going to modernize the public health, moving forward, whatever they're going to modernize is going to affect us to the core, whether it's funding, whether it is the standards or the stuff that we believe in. And you alluded to some of them, Mr. Chair, as well as others, dealing with the whole issue of equity, the issue of stable fundings, and what have you. So I don't know what the final outcome of our discussion will be in terms of recommendation of this piece of consultation, but we really need to make sure that we verbalize both in writing and those who are attending the February 10th meeting to indicate what our guiding principle for this board that we have been championed now for over a year or for many, many years at Toronto Public Health. Because what I'm concerned about is that if we don't proactively, and I think Director Perks indicated earlier, that we got to make sure our concerns, our advocacy work for decades on public health doesn't get diminished as they modernize what is public health for the province. Because at the end of the day, this is going to be stuck with us in terms of future funding. But more importantly, what is the role for staff, but also for our mandate as a board? So I think that some of the motions that the chair has put forth, I think is very valid. I think we need to move forward with some very strong language of what we believe in. Thank you.
Thank you. Director Perks.
Thank you. I'm profoundly concerned about this moment for public health. Yes, we did survive last year a budget attack, but I'm looking at this, I'm just terrified. To begin with, the word modernization, I haven't a clue what it means. It can mean anything. There's nothing in anything I've seen communicated from the province of Ontario tells me what is different between the moment we're in today and the moment we will be in 10 years from now, and how modernizing gets us from one to the other. It's an essentially meaningless discourse. And when you've got something meaningless that you're being asked to participate in, that means you have no idea what the real outcomes that are imagined by the province might be. And that's the terrifying thing. One of the things that I think is most important about public health is that unlike the rest of the medical system, which is dealing with a patient to improve a health outcome with a disease or some treatment or medicine that you want to do, is public health talks about health on a population level. And because it talks about health on a population level, it automatically finds itself interrogating questions of the inequities in our society and the health impacts of those inequities. In other words, it's built in that it asks hard questions about how our society is organized. And I fear that when you have a combination of a meaningless process, modernization, and a specific attack on that part of our health system, which raises the difficult questions about how our society is organized, who benefits and who does not, that we need to be better prepared than what we've been able to achieve in the very short amount of time that the province has provided for us. And I just want everyone to make it a bit of a priority over the next couple of weeks to jot down some thoughts, to think about how you can communicate directly with the chair or the medical officer of health, or find time to meet in small groups. We need to be able to articulate the case for why public health is so important to the broad social health outcomes and equity in our city.
Director Donaldson.
Thanks. And just to build on what Director Perks and Director Wong said, I think it's really important that what we do put forward, that we are very deliberate about making it extremely public. Working in the education sector, I've now been through one of this government's largest consultations in the history of the province, where it's a quote, where the results still have not been made public. I'm not sure that they ever will. But there's been several organizations who have done polling. The feedback from the public has been loud and clear, yet the government refuses to share the results of this consultation. So I would urge this board and the medical officer to be really explicit about it, making our needs and our concerns public. And I would also ask that you urge other local public health units to do the same, because our communities really deserve to know, and the whole province should know as well. Thank you.
Thank you. Other speakers? Director Mulligan.
To build on what the previous directors have said, it's important that this board take a leadership stance. We have a reputation nationwide for taking leadership when it comes to population health and health equity. The ministry itself has said that they have pressed the reset button on public health, changes to public health, and that they're asking for vision. And we have an opportunity to put forward a vision, a positive vision of what we think the role of public health and population health and health equity ought to be in this province and in this city. We're not there yet. And we have not much time. I'm concerned that the date of our in-person consultation is the same date as the date of the end of consultations. When realistically will we have an opportunity as a board to sit down and put together a coherent vision for public health and population health in this province? The timing seems very challenging. The discourse around population health is worth noting, that Ontario health teams and the healthcare system integration has been tasked with population health management. Is that the same thing as population health from a public health perspective? Who's going to be responsible for what? I think there are a lot of questions there, and I think it's important, in the history of public health modernization papers that have come out over the last 20 or even 30 years, the tendency has just been to push back and say, no, we won't relate with the healthcare system. We're a separate system. And I think we need to challenge that. I don't think that's got us where we need to go. And we need to have a very frank conversation about what is the relationship with the healthcare system and those organizations, such as those in comprehensive primary healthcare, for example, that might blur the boundaries a little bit more than is depicted in on page 8 of the presentation, that the healthcare system only deals with individual clients and public health only deals with populations. That's about to change. And how we define a population may change. And what we think about as local input, local accountability, local governance, whether or not that needs to be identical with municipal is something that I think is something that we need to have a conversation about as a board. So I think there are a number of things, and so I just wanted to register my concern about the time and the opportunity to reiterate the positive opportunity we have to set forward this vision. Because these consultations, these kinds of quote-unquote modernizations, they come and go. This is one. And it's our opportunity, if we can clarify a longer-term vision of what we think really needs to happen, we can continue working toward that vision regardless of changes in provincial flavor. Thank you.
Thank you. Any other speakers? All right, I will speak, and I'll begin by placing an amendment which is being advance circulated. Let me start, first of all, just by thanking our staff for bringing forward the presentation and the report in front of us. I know when a discussion paper was released at the end of November, we made this request in the beginning of December, and it's early January. Welcome to the process that's underway. As Director Mulligan was just saying, there have been decades of discussion in this province related to public health, the organization and funding of public health. Some of those have been reactive. In response to a SARS or a Walkerton, we saw significant shifts in the funding framework and some level of coordination around Public Health Ontario. Some of it has been proactive, whether it was the last government proactively putting forward a vision around reorg, one that was controversial and didn't completely come to fore, but it was a proactive step, or in the case of this province, proactively without vision, but rather the sole vision being that of cost cutting, putting forward a proposal last April. So that process, which was proposed last April, thankfully has been somewhat reversed and we're back into a reset. So my concern going into this is that this, from the provincial side, I'm not sure what is driving this reorg completely. When I read the discussion paper, I see a lot of language around coordination, alignment of services, but I don't see discourse of health equities, population health writ large, and how you best accomplish those objectives. And I also don't see a lot of the principles that have guided the effective delivery of public health services and policy over many years with regards to stable funding, local governance driving the process. And so as we go forward, we made a request in December that there is a direct engagement with this board. And I'm glad that it seems like it will be happening on February 10th, still to be confirmed. I'm not comfortable as a chair or even just as a member of this board simply going into a consultation hoping that that a good outcome is going to come from it. I think some clear principles need to be conveyed and communicated in advance of that meeting, which my amendment speaks to and communicated. But I also think, and this is a challenge with how quick the process is and the uncertainty of it, is I do have a level of concern around our preparedness for that, and I think Director Perks was speaking to this. And so while the amendment I have in front of us is to endorse some clear principles, and on behalf of this board to convey those in advance to the province and with this board so that we are more prepared, I think when it's clear who is able to attend on the 10th, that the onus will be on me, and I'll ask for the medical officer of health's support so that those who are attending, so that we can convene to chat in advance, be it to workshop or via conference call. I just also note that province-wide, through our office, we are liaising with other boards of health and sectors who are engaged, starting to have those conversations with sectors who were engaged in April, within the food policy community, within the student nutrition community, and we know that that outreach needs to take place. And so I'll simply close by saying this is an uncertain moment in public health in this province. I believe that the obligation on us is to more than monitor it and provide feedback to it, but to proactively engage. It's challenging when we as the local public health body for Toronto are tasked with coming up with an overarching provincial model for them because we don't necessarily have faith in this government, but circumstance requires us to be a little more proactive. So that we do more than successfully stop a bad decision, but proactively help to shape a positive system going forward. And so with that, I'll conclude my remarks. Are there any questions of me with the motion? Yes, Director Mulligan.
I guess my question is around whether we have the mandate to speak to integration with local municipalities, 1A. That are not our own, given that other boards of health are organized differently and not all are explicitly linked to local municipalities?
So the intention here in terms of guiding principles is to speak to the importance of integration with local municipalities writ large. rather than to provide a prescribed measure for each and every other one. Okay. Any other speakers? Okay, seeing none, then we have an amendment in front of us. All those in favor? Opposed, if any? That carries as amended? Nope, just that. Okay, thank you very much. And thank you to Eileen, you and your team. We will now move on to our next item, which is item HL 13.7, Mobile Dental Clinic 3-month pilot of service delivery model. Do we have any speakers on this item? We do not. Okay, so there was a report submitted. Questions of staff? Yes, Director Wong-Tam.
How many individuals are served by this particular service, and do we have a breakdown of where they're coming from, the ages and genders?
Yes, through the chair, we see approximately 1,700 clients annually on the mobile bus. Each individual agency, it depends on the demand on that day as we arrive. On average, it's about 7 clients per day when the bus is at the agency.
And so would you say that each client needs about 1 hour of assistance, like once they're into the dental chair? And that includes consultation?
Again, it varies. Some clients do take more than an hour. Some clients take more than, maybe half an hour. It all depends on their needs. We basically design their treatment plan and their consultation and their when they arrive at the bus. So, on average, maybe an hour, maybe a little bit less.
And so because the vehicle requires this extensive repair, can you explain the stopgap in the service that you're about to introduce to sort of fill the gap? Like what would that transition look like?
Well, we would have we currently do have our street outreach worker working in the program. The stopgap measure would be to have the street outreach worker plus a clinical staff member attend the agency and provide the consultation and their pre-treatment services done at the local level. And when they do require the treatment services, they would be shuttled, driven, provided service at the clinical level in one of our 24 clinics.
So therefore, there's no real plan to replace the mobile unit?
For now,
Sorry, through the chair, I think the issue is that the fact that the mobile dental clinic requires this significant investment only came to our attention relatively late in the year. So in fact, it is not operable right now. So this is an opportunity for us to continue to provide services to a population that really needs this service and is quite vulnerable, and as well to provide service to a greater number of clients. The model that's being proposed should allow us to provide, or at least give us the opportunity to provide service to a greater number of clients for the number of hours of operation. And at the same time, that gives us the opportunity to explore, because it does take time to put things through, to have a sense as to how much will it cost to either repair the mobile dental clinic or acquire a new one, depending on what the particular, what the assessment of the vehicle provides for us. We have to do some investigation in order to invest further. And there is, that will have to be done because given the timing, it could not be inserted into the capital budget. We actually have to make the adjustment to our capital budget within the first quarter. So that all does take, unfortunately, a little bit of time. And what we're trying to do here is preserve service in the interim.
And under the prior model, the street outreach worker who actually was the individual that actually drove the mobile dental clinic. And if we were to get this program up and running, would that still be the best use of a street outreach worker's time? Because when you're driving the bus, when you're driving the clinic, you're not actually working face-to-face with the population that you're trying to serve. You're just basically a driver.
Right. I mean, the best use of the street out workers' time is to do outreach in the individual, in the community. However, we've tried to explore many models about driving the bus to the specific location. We'll have to explore further, but it was a challenge to get just a driver to drive the bus for an hour to a location.
So just to understand, so the revised service is to actually do the outreach in the communities and the agencies where people are already receiving other services, and then you'll be chauffeuring them, transporting them to the other clinics that are brick and mortar clinics to get their assessments, to get the dental treatments that they need.
That's correct.
Okay. And then there will be the report back.
That's correct.
Thank you.
Director Wong.
Thank you, Mr. Chair. So we receive a communication from Vicki Rennie about this particular report, Mr. Chair, through you to the Medical Office of Health. So this particular deputant asked that, what does she say here? She said she's encouraging Toronto Public Health to reach out both the mobile denturists and dental hygienists to be included in this project. So through you to the Medical Office of Health, is that being considered as this alternative dental model that's being suggested?
Through the chair, can you repeat that? Is that denturist?
That's what it said. It was a handout that's given to the board members that that this particular deputant asked that she's encouraging the Toronto Public Health to reach out to, quote, both the mobile denturists and dental hygienists to be included in this pilot project. So I just want to know if this is being considered for this 3-month pilot project.
So through the chair, that option is not currently being considered for part of this pilot. I would suggest, however, that in part and parcel of our regular, how do we continuously improve our service, if there is benefit to incorporating different models of care, I think we should always be open and exploring what are the different models of care and does it make sense within the context of our working environment and to serve our clients. So that particular, we just got the communications as you did today. We'll certainly take it back and determine. I don't think it will be part of this pilot, but certainly happen to look at it as part of a how do we constantly improve our service? Is this an opportunity to do that?
And my last question, Chair, through the chair to the Medical Office of Health. When the 3-month pilot report coming back to the board, can we get an idea with the new funding from the province for the dental program, how would that help, especially those vulnerable residents that we have? We're supposed to be improving the dental care. And more importantly, how do we ensure that this is a city-wide initiative? Because oftentimes I raise that concerns when the mobile clinic was out in Scarborough, and we didn't really know about it, and then we see it in the middle of the parking lot. So it would be really good in the 3-month pilot project that the report comes back to the board, we have a cross-sectional review across the system, how we deliver this new alternative dental program.
So through the chair, the Ontario Seniors Dental Care Program actually has some very specific requirements of it, and that actually is service that's delivered to eligible seniors throughout the province, and it's within the context, and I'm going to turn to staff, public health clinics, any public health clinic through Aboriginal Health Access Centres and through CHCs.
Community health centers.
So community health centers, excuse me. So there are some very specific requirements for that funding. That actually is quite separate from this. That's not to say that there aren't vulnerable and eligible seniors who might actually be taking advantage and capitalizing on the service that we provide or that we have traditionally provided through the mobile dental clinics. I can assure you that the report that we bring back will give you a sense as to what we determined through the pilot and we'll offer some suggestions for you to consider in respect of how best to provide good quality dental service to those who need and to those who would benefit most from the model that has traditionally been delivered thus far.
Thank you.
Thank you. Any other questions? Okay, seeing none to speak. I'll put myself on the list. I have an amendment, if it can be moved, and it's specifically to request the MOH to report at the end of the pilot on the interim delivery model, the alternate delivery model, specifically on two fronts. One is a review of the performance, and the second is any information on additional funding required to sustain it. So let me tell you what, as I see it, the goal and the concern I have. The goal, obviously, is anytime we can enhance the quality of dental services that we provide for our marginalized population, that's a good thing. That's what we're trying to do. Where the concern I would have is the vehicle breaks down, therefore we stop funding the vehicle and we get worse service. That would be a bad thing. And so I want to thank our staff for moving quickly when the vehicle broke down to come up with a model to ensure the continuity of this service. That's good. If we can do it better, that's great. But I want to make sure, because I know the report mentioned that we're going to evaluate it, I would like to ensure that we have at the end of this period a report back to the board with these considerations so that we can evaluate, are we enhancing the level or are we seeing a reduction in service quality? Any other speakers? Okay. All those in favor of the amendment and as amended? Any opposed? Seeing none, okay. Moving on to our final item, HL 13.8, Subway Health Impacts Study. Do we have, we don't have a presentation on this. No, we don't. Okay, so we have speakers. There is a speaker listed, Hamish Wilson. Hamish, we see you at other committees. We don't see you as much here down at the Board of Health. Welcome.
Well, the real work is for cleaning up our mobility and changing it tends to be at the other committees, not so much here, even though you do a lot of good work, and it's been really hectic for you with our Doug Tater blowing or trying to blow up many things. And he's not getting away with it. Thank you for pushing back. Decades back, I got interested in air pollution issues through acid rain, which also, we couldn't just point fingers at the U.S. We had to have clean hands and look at what we're creating within our own city, and that led to mobility issues in cars. I did realize from that there's an awful lot of pollution around that we don't actually see. You can almost see the pollution sometimes if you have a strong light source that's kind of not in your field of vision. You can see the haze. So if you're seeing that sort of haze and a beam of light in a subway tunnel, if it's mostly fine particulate, there's definitely a problem or a set of problems. So I really hope that we'll take it quite seriously. I'm not sure, it's not so clear from the summer report where the pollution is coming from, however. Is it from braking? Is that the major thing? Is it the seepage in of contaminated air from street level into the subway tunnels? Is it from maintenance and welding activities? Is it recirculation of as a train comes in to a station, does it disturb the dust? It's not entirely clear from the intermediate level report where exactly the problem is from. Another issue that I don't see that again, not in the summary, and I should have explored further, are there any variations by season, by time of day? Is it concentrated in the older parts of the system? Line 2 is worse. It is an older part versus an older part of the system versus line 2, or line 1, which is very extended now with new stations. So is it concentrated in the old parts of the system? And I think your options to fix it are a little weak as well, unfortunately. One option that might actually help is to try spray painting, to see if that actually helps to seal in some of it, especially as you approach stations, perhaps. Could be wrong. At least give it a try, see if it makes a difference. And one of the other things that I think is really important, there's another wonderful mobility option. Instead of just saying to people, hey, keep on taking the subway and paying a lot for it, why not really encourage better biking along the Bloor and Danforth? That is part, or should be part, of the public health solution proposal to alleviate the air pollution, because it's not just about the safety of the passengers, TTC passengers within the system. Biking is much, much better for us all told. And we should know by now that we actually have a lot of pent-up, this comes up, yes, we have a lot of interest in seeing cycling on the Danforth by our crash stats. Bloor Danforth has been consistently one of the more traveled corridors, and it doesn't have the streetcar tracks, which actually create a lot of issue for people. So it'd be easy to repaint. I know we're finally getting to repaint, studying it again to repaint things, but it's really, really slow. So it'd be great to have the Board of Health express support for having a continuous bikeway all along Bloor and Danforth. We're studying it this year, but unfortunately there's also a key gap that's being missed, it seems. Have I got this the right way? Somehow, from Sherbourne over to Church, that little bit was in the 2001 bike plan, the remnant of stage 1 from the 1992 study. That's still not good enough. And I think it's missed in all the studying that's going on. So please, 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 it would be really helpful to have, if you're going to make a motion to support a bikeway, try and get something done this year. Doesn't have to be a bike lane right away. I'd be happy with the Sharrows because it'd be something. There's a condo construction. I'm almost out of time. Another thing that would be really helpful is to encourage the city to actually do a better job on the winter maintenance. This is from last year. It's a pinch point. It's a highway on Bloor East at the top of Parliament. The bike lane becomes a bike line often, and that's not okay. Unfortunately, we have less competence in the repaving as well, unfortunately. Fresh repaving, which is wonderful. There was a bike lake there at that same point, just around the curve prior to painting. And then recently we just had repaving, but it's still not okay. You know, it's a pinch point. It's really, so in order to really have that mobility option made safe, which is something that you should do to respect all the transit users, because this is sort of how we're at. There's the pedestrian, there's the bike, that's your subway, your transit, and there's the private car. Thank you. I'm over time. I'd love to go on, but thank you for your time and trouble. And there's an awful lot of hazard on street, and it has to be made safe. One final thing.
Sorry, you're already, Hamish, you're just over time.
Yes, it'd be great to have, in terms of road safety, great to ask the coroner for a review of all the crashes in the last decade to see if the lack of enforcement has actually contributed to real mortality.
Okay. Thank you very much, Hamish. Are there any other members of the public here who wish to speak on this item? Okay, seeing none, we're going to move it into committee then. We'll start with questions of staff, and I'd note for members of the board, we have a report here from the Medical Officer of Health, but we do have staff here from the TTC if there are questions of them as well. Okay, let me open it up. Questions from staff, or questions to staff. Director Wong.
Thank you, Mr. Chair. So I threw you to the Medical Health. With regard to this report, it focused primarily on the health benefits or the issues affecting the health of the passenger. There's no references that I read dealing with the workers, because we're just visiting the subway, yet are we not concerned about the employees of the TTC who's there longer than we will be on the subway?
So through the chair, as Medical Officer of Health, I have authority on the public, but not in respect of matters that relate to occupational health and safety.
Thank you.
That falls under the purview of the Toronto Transit Commission itself.
Okay, that's all I want to know. Thank you.
Thank you. So I have a couple questions. I mean, I think members of the board have probably had time to drill down into this. It's been very prominent for the last little while. As it relates to PM 2.5, the fine particular matter, am I correct in my understanding that there are no guidelines at the federal level or at any other level to what the level of PM 2.5 should be for passengers?
In short, through you, Mr. Chair, that's correct.
Okay, so I know in doing the independent health assessment, you have assessed that there is no immediate risk. In fact, I've seen this, that the advice is that taking the subway is good for your health, but could be made even better with mitigation. But why no recommendation or request for the federal government or others to create guidelines on PM 2.5 so it's not up to us on our own?
So through you, Mr. Chair, clearly it would not be up to us on our own, and I think it's reasonable to ask for those guidelines to be created or standards. I expect that it might be challenging for some of our federal partners to do that. There is no, we know that PM 2.5 is one of those exposures, if you will, that really doesn't have a threshold or no known threshold, but I expect that our counterparts would have some challenge in putting those together. I don't think that there's a harm in asking. I just expect that we should have reasonable expectations around what might emanate.
Okay. Are there, and I know this is an emerging issue for subway systems around the world, and there's London and Paris and others have looked into this. Have other nations or have other jurisdictions established clear guidelines around the level of PM 2.5?
Through you, Mr. Chair, no. We know of no such guidelines that have been established. We know that there is, interest, and people are looking into this. This is a relatively new challenge, and other subway systems around the world are also trying to, manage and figure their way through this.
Okay, and then I recognize I summarized your report at the beginning of my question, so I would like to give you the opportunity. In your assessment, and is taking the subway good for public health today?
So in short, through you, Mr. Chair, when we did a health impact assessment, and the overall conclusion of the health impact assessment is that taking the subway and encouraging subway use is something that we should be doing, both as a Board of Health, as a public health department, and we should be encouraging people throughout the city for a wide variety of reasons. There are a number of positive health benefits articulated in the report.
For passengers, for our riders in the city on the subway, is there an immediate health risk based on the level of fine particulate matter that's been identified?
So the health impact assessment concluded that no, we should be encouraging people to continue to ride the subway. That being said, the levels of PM 2.5, as recorded in the study, suggest that there is benefit to mitigation, and that by engaging in those mitigation actions, we would enhance the health benefits of riding the subway and using public transit.
Okay, so while there is no immediate risk, with further mitigation, it will improve, it will have health benefits?
Yes.
Okay, thank you. Those are all my questions. Director Donaldson.
Thanks. Through you, Chair. I thank you for this report. I noticed on page 7, there's a section entitled Mitigation is Especially Important for line 2. And it says that the PM 2.5 exposure level during weekday rush hours for line 1 is 85. I actually don't know how to say that measurement. Micrograms. And on line 2, it's 183. So in our findings, or the findings of Toronto Public Health, are there factors that we determined that are contributing to a 100-point difference between the two lines?
So through the chair, the factors are not really entirely clear, and we know that that's not only the case for Toronto, but it seems to be the case as well, based on our assessment, for the other jurisdictions as well. So that's why there's a real opportunity and for the TTC to engage in this and to conduct further study in partnership with Health Canada and with the industry and other researchers. That's what was referred to in the report.
Okay, thank you.
Okay, Director Mulligan.
Thank you for this piece of work. I have a quick question about risk communication, which I think is part of the underlying unspoken work of this. So, okay, let me just get right to it. Under 2D, monitoring levels of subway PM 2.5 and evaluating, is the intention that, given that these would be monitored, that the monitoring results would be made public?
So through the chair, the monitoring that has been done to date has been done through in partnership between the TTC and Health Canada and some other research partners that are brought on board. Our understanding is that that partnership and collaboration is expected to continue. And to date, most of the results have been coming out through publication. So further public reporting from Health Canada would be a question that we would have to direct to Health Canada.
Okay, so in follow-up to that, do you see that there may be an emerging role for Toronto Public Health in supporting risk communication around contextualizing and understanding those results?
So through the chair, I think there's always been a role for Toronto Public Health in respect of contextualizing results of studies, whether it's with respect to air quality or any other exposure in the city, so that people can understand what the circumstances are here. That being said, the broader monitoring and the studies and the collaboration are actually occurring between the TTC and their other research partners, which include Health Canada.
So given that you said that there is no established sort of safe level of exposure, on what basis are the decisions made around what constitutes risk and harm?
Well, I think the issue here in respect of PM 2.5, and I'll ask staff to contribute further if they feel that I've missed an important point, but there is exposure to PM 2.5 regardless, right? PM 2.5 exists in our environment. There is an opportunity to actually rectify what's happening currently and to mitigate what's happening currently in this environment as described in the report. The thing is that we know that if we do not encourage greater use of public transit and other forms of active transportation, for the reasons articulated in the report, actually there is risk associated with the broader environment and actually degrading our external environment even further. So there is an opportunity. This is still an emerging area of research. We are just starting to understand PM 2.5 exposures within the subway. That is not unique to Toronto. That is in all other subway systems that are similar to that which we see in Toronto. So we now know something new that we didn't know before, relatively recently, and we have, I think, a responsibility and an obligation to work with our partners to ensure that we address that. How it's best addressed, I think, is still very much a question and is an area of further study and conversation within subway service providers, amongst the research community, and I would say amongst health authorities writ large.
Thank you. Director Wong-Tam.
Yes, thank you. Recognizing that the particular matter in the subway tunnels and on the platforms is sitting at 2.5, what is, just to compare, what is a normal reading in an environment just above grade?
So through the chair, when we talk about regular in our city, for example, above ground is in the range of 7 to 10 micrograms per cubic meter.
And so with respect to, I think Hamish is still here, he asked some questions which I don't believe are answered in the report, but what is causing the increase of the density of particulate matter in the subway tunnels and platforms? Is it the brakes? Is it the lack of external air intake circulation? Why the higher concentration? This is probably a question for TTC.
So through the chair, it probably is better answered by our colleagues at the subway, but I would tell you this, my understanding is that that has yet to be determined. Those are all reasonable hypotheses, but the definitive answer has yet to be determined. Again, this is a relatively new understanding that we're coming to. And when I say we, I don't mean just Toronto. I'm talking about subway system operators writ large. Or operators of similar subway systems. Let me be clear about that.
Maybe if I can ask, do the TTC staff have anything else to add to that? Are they here?
You need to be.
Thank you. Sorry.
Hi, through the chair. Not particularly at this time. We do have some hypotheses, as Dr. Davila did say, but a lot of the materials are consumable. So it's steel rail on steel wheels, and these do deteriorate over time. So, but there doesn't seem to be sort of a smoking gun at this point that we can pinpoint to.
And because the report, and thank you, that's somewhat helpful, but because the report speaks to the fact that this is somewhat of an acceptable level, but we should try to reduce the density of this particular matter in the subway, it also speaks to the fact that there could be effects for those who have chronic respiratory challenges. I'm a sufferer of asthma, so oftentimes when people tell me that the environment is accessible to someone who's actually living with respiratory challenge, it's actually not very acceptable. So how do you distinguish between what is acceptable and what is not acceptable, especially for those who are actually living with some respiratory challenges, lung or heart disease?
So through the chair, this report speaks to the general population writ large, and it is an assessment, and it talks about the health impact assessment, and it provides advice in general that taking the subway, using public transit is actually a good health promoting, health supportive endeavor. That being said, for individuals who have very specific medical concerns and medical conditions, whether we're talking about heart or lung conditions, the advice that we've provided is that if you have those concerns and are having particular challenges or have questions in respect of what's best for you as an individual, that's done, we feel, best in the context of a conversation with your healthcare provider who's knowledgeable around your specific medical conditions and what triggers worsening or exacerbation of your medical condition. That cannot be done in a general level.
Okay, thank you.
Isn't best done that way.
I would have some difficulty imagining that a medical practitioner suggesting to a patient, I'm going to advise you to avoid taking the subway because there may be an environmental trigger in the tunnels and platform to your respiratory challenge condition.
Yeah, sorry, through the chair, that may be the case, but in fact, in medical practice, we know that there are a number of conditions. So for example, on those really hot, smoggy days, we know that medical providers will often tell their patients who suffer from more extreme forms of heart or lung disease to be mindful around perhaps not engaging in vigorous activity or exercise outside. So those kinds of individual, sort of individually focused pieces of advice are best offered in that context, or increased puffer use or what have you. Those are the kinds of things that can happen within that context.
Okay, thank you.
Okay, any other questions? Okay, seeing none to speak. Director Donaldson.
Thanks, through you, Chair. I just wanted to highlight a motion that I put forward. Is this the appropriate time?
Mm-hmm.
In respect of placing a priority on line 2 when we're looking at mitigation factors. A number of times in the report, it's mentioned that our findings show that there is a difference between line 1 and line 2. And so I think it behooves this board to be sure that we are making sure that that's highlighted, that there are some differences in line 2, and to also give the good folk who are riding line 2 every day a little bit of assurance that the Board of Health is looking out for them.
Thank you. Okay, that amendment has been placed. Anybody else to speak? All right, I'll make a few comments. If I could begin first by placing an amendment that the board encourage Health Canada to continue its research on air quality issues in the TTC and to establish health-based guidelines for PM 2.5 in subways. So let me begin, first of all, by thanking our staff. A request was made in 2017 for Toronto Public Health to assess the air quality for passengers within our subway system. And an exceptionally large amount of good work has been done and hard work to get to this point. And it's hugely important. As we've seen in the report and heard from Dr. Davila, this is the issue of air quality and air quality within subways is an emerging issue around the world in subway systems. And I think if there's a message here, the message for residents is certainly that our subways are indeed safe, but with further mitigation, there can be further health benefits. So that's, to me, the message to residents. I think the message to the TTC, and we've heard them welcome this report and express their thanks not only to Toronto Public Health for the report, but also their commitment to conduct mitigation. I think if there's a message to the TTC, it should be to aspire to be a world leader when it comes to air quality. Don't be satisfied with a pass from the medical officer of health. Use this as an opportunity in partnership to further improve the quality and the air quality. And I think if there's a message to the federal government and Health Canada in particular, it's not only to continue that research, but to establish health-based guidelines so that you don't have an ad hoc situation with different jurisdictions looking at this issue differently and coming up with their own conclusions. And so, in conclusion, this report here is going to City Council. It will also be at the TTC board. And I know Director McKelvey here is on the TTC board as well as one of the commissioners. And so this is not the end of this by any stretch, but also I think it reflects and reinforces the role of Toronto Public Health in this city in that we are more than an evaluator. Dr. DeVille is not an accountability officer who's going to come over and tell you how you're doing. Rather, we're a partner in this. And we're a partner in not only helping to identify and assess potential health impacts, but also to improve them. And this is just as the TTC has warmly embraced this work and this report, this is a signal and an open invitation from us to the TTC to continue to work in collaboration to further mitigate and improve the health. And with that, are there any other speakers? Okay, seeing none, we have 2 amendments. Do we want to take everything as a package, the amendments and the motions? Can I ask for a recorded vote on this one for the board?
Okay, so all in favor of the 2 amendments and adopt as amended? So Director Ashna Bowery, Director Stephanie Donaldson, Director Mike Layton, Director Kristen Wong-Tam, Director Joe Cressy, Director Jennifer McKelvey, Director Kate Mulligan, Director Gord Perks, Director Peter Wong, and Director Sue Wong, and that carries.
All right, so that concludes our meeting. So thank you very much. A very happy new year to everybody, and we'll see you all soon.
There's no space. You're not pushing that.
Yeah.
So.